So, hello, good evening, everyone. Welcome to the next edition of physiology classes. So, today we'll be discussing two very important topics. The first one is blood, and the second one is endocrinology. Both are extremely important chapter. So, it's a long chapter. We'll be discussing the theory part very quickly, and then, as and when the MCQ comes, we will discuss in brief. Okay, so let's start. So the basic idea is to revise your theory part and then give you the glimpse of the MCQs. Then after hearing this class, when you go back to your MCQs, you can really solve MCQs at a faster rate. Let's begin. So the blood, as you know, the properties of the blood, the color of the blood is arterial blood. So, I'm sorry, the arterial blood is scarlet red in color, and that is very high in oxygen. That is why arterial blood is bright red or scarlet red. Whereas the venous blood is high in carbon dioxide and the color of the blood is purple red. The volume of the blood is adult is 5 liter, 5 to 7 liters, let us say 5 liters generally, females is 4.5 liters. Then the reaction, it is slightly alkaline 7.4, basic in nature. And the specific gravity of the total blood is 1.052 to 1.061. So these are all the high yielding facts. There is no variations in this. You can't change this. This is the way it is. So you need to learn this. So these are direct questions. Viscosity is 5 times more than water due to RBCs and plasma proteins. Because RBC, WBC, platelets will be there. Plasma proteins are there. Albumin, globulin, fibrinogen. So because of which the viscosity is 5 times more. So these are the high yielding facts. So as we know, the blood cells are of 3 types. RBC are called erythrocytes, WBCs are called leukocytes, and the platelets are called thrombocytes. So you should know the applied aspect of all of them. If something is increased, what is the condition called as, and if it is decreased, what is the condition called as. So that is the basic thing where majority of questions are asked. So the composition of the blood, when you see that the blood is made up of 7 to 8% of solids, where the water content is 92 to 93%, and there are some gases also. So the gases are oxygen, carbon dioxide, nitrogen, and then in this organic substance, you have got variety of things, starting from plasma proteins, which are albumin, globulin, fibrinogen, then amino acids, carbohydrates, fats, internal secretions, lot of enzymes are there, and non-protein nitrogenous substances are there. So along with the organic, you have got inorganic substance also. So the inorganic substances are sodium, calcium, potassium, magnesium, and the things goes on. So please learn the composition of blood. So that is, the first one is the properties of the blood. The second one is the composition of the blood. Now, coming to the plasma proteins. So there are 3 plasma proteins, as we know that: albumin, globulin, fibrinogen. The total plasma protein is 7.3 grams per deciliter. So it's extremely important. You should know the units also and the range also. 6.4 to 8.3, it varies. Out of which the albumin is the highest, that is 4.7 grams per deciliter. Serum globulin is 2.3 grams per deciliter and fibrinogen is 0.3 grams per deciliter. So they can ask you increasing order, decreasing order, just assemble that. So based on this, when you see on keen observation, the ratio of albumin to globulin is 2:1. So 4.7 is to 2.3. So that is 2:1. That is the ratio. So you should see the questions very carefully, whether they are asking albumin is to globulin or globulin is to albumin. So according to the question, the answer changes. So as you know, your RBC, the count is 4 to 5.5 millions per cubic millimeter of blood, and in females it is little less, 4.5 millions per cubic millimeter of blood. And the lifespan of the entire RBC is just 120 days. So that is equivalent to 4 months. So within 4 months, the blood cells will shed off. So when you see the structure of RBC, it is biconcave in section view. Okay, so that is the biconcave in section or the view. So this biconcave nature of the shape of the RBC is actually very advantageous for it. So what are the advantages? Because of the biconcave, rapid diffusion, so air, oxygen can penetrate very fast. Then it provides a large surface area for exchange of substances. Then reduces the membrane tension, and RBCs can squeeze through tiny capillaries without damage. So this is extremely important. And the diameter is 7.2 microns, and at the biconcave, the thinnest area it is 1 micron. So these are all the high yielding facts. This comes as MCQs, so not to forget that. So now what happens when RBC breaks? So our hemoglobin is destroyed in spleen, reticuloendothelial system. And the major component of RBC, what comes out is hemoglobin. The color of the red blood cells is because of hemoglobin. So the hemoglobin, when it breaks, we get three components, that is iron, globin, and porphyrin. This iron plus apoferritin gets converted to ferritin and they are stored and reused. So even the RBC is broken down, this iron plus apoferritin is again reused for the body. The globulin component breaks down and becomes the protein pool and stored and reused. So both of them, iron and globulin or globin is reused. But the porphyrin content gets converted to bilirubin and it is excreted out of the body. So this is what you should be knowing this. So two components are reused, only the porphyrin component is excreted out. So this RBCs again, as per the different conditions, it increases and decreases. As per the age, it is high at the birth and it decreases in 10 days after birth. And again, in children, it is a higher level. When it comes to adult level, again, it comes down. So the reason is destruction of RBCs takes place. Then RBC content is little more in males, but in females, it is more during the reproductive period because of the hormonal differences. At high altitude, RBC content is more. Muscular exercise, RBC increases. Emotional conditions, RBC increases. Increased temperature, RBC increases. And after eating meals also, the content of RBC increases. So the reasons are given there. You can again go through this presentation and learn it. So there are some conditions where RBC content decreases also. In high pressure area, barometric pressure area, RBC content decreases because more oxygen, then less RBC production is there. Then during sleep, the content of RBC comes down because body activity decreases. And during pregnancy, RBC content decreases because hemodilation occurs and due to which the plasma volume increases. So it becomes what diluted. Okay. Now the types of this condition, RBC. So there are two types, primary and secondary. I am talking about the increase. So the increase is called polycythemia vera, where the RBC count is greater than 14 millions per cubic millimeter of blood. Generally, it is 5 millions per cubic millimeter of blood for males, and females it is 4.5. But here you see a condition when it is 14 due to bone marrow malignancy. So that condition is called polycythemia vera. And the secondary condition when increase in RBC, that is caused by hypoxia. So that is a stimulant, or respiratory disorder, congenital heart disease, chronic carbon monoxide poisoning, chemical poisoning, repeated mild hemorrhages. So these are the conditions where the RBC count again increases. So different types of the size, based on the size, the RBCs generally 1 micron is the diameter, right? 7.2 microns is the diameter in a normal way, and in the biconcave 1 micron. But the size can vary. So the size, if it is small, it is called as microsize. The size of the RBC decreases, and that condition is iron deficiency anemia. Whereas the RBC assumes a bigger picture, it is called as megaloblastic anemia. And some are big, some are solid. small, it's a mixed type. That condition is called as anisocytes. So microcytes, macrocytes, and isocytes, and the condition is pernicious anemia. So these are all framed into MCQs. Next, coming to the shape. So based on the shape, it's called crenation or crenated one if there is shrinkage in hypertonic condition. Spherocytosis, globular shape. Elliptocytosis, elliptical shape. Sickle cell, crescent shape. And poikilocytosis, unusual shapes. These are the various shapes of RBC. So based on size, based on shape, we have discussed that. We should know the conditions in which the shape occurs. Again, the size, this we have already discussed. The condition when hemolysis occurs, when your RBC breakdowns from your body, three conditions: hemolytic jaundice, antigen antibody reaction, a massive reaction is taking place, or poisoning by chemicals or toxins. So these are three conditions where the RBC content of your blood breaks down, hemolysis occurs. Now coming to erythropoiesis, that is the formation of RBCs. So at different stage, RBC production is done throughout life. So at a fetal life, it is done at three different stages or three different places, we can call it. So in the first trimester, that is called mesoblastic stage, RBC production takes place from mesenchymal cells of yolk sac, extremely important MCQ. Then the second trimester, that is called as hepatic stage. So mainly liver is the one which is manufacturing RBC. And third stage is called myeloid stage. There your red bone marrow, RMW, red bone marrow, the marrows are making the RBC. So that is why it is called as myeloid stage. So yolk sac stage, liver, and red bone marrow. So three different stages in the fetal life. Then when the child is born, up to first 20 years, from the red bone marrows of all the bones it makes, all the bones. Then when the child crosses 20 years, it becomes an adult, then only membranous bone and ends of long bones, these two bones only make the RBC. So this is again an MCQ. A lot of bones will be given, so you should know which are membranous bones. So different stages of erythropoiesis. It starts with the first pro-erythroblastic stage, normal, early normoblast, then intermediate, and then late normoblast, reticulocyte, and mature erythrocyte. So the coloring also, first it will be basophilic or blue in color, and slowly when it is coming towards mature erythrocyte, it becomes eosinophilic or red color staining takes place. So these are the different stages. In each stage, how the cytoplasm will be, how the nucleus will be, what will be the size. So these things you should be learning properly. Please take a screenshot of this. This will help you to solve many MCQs. So example, in early normoblast, what are the key features? Like nuclei will be absent, present, bifurcated, or none of the above. So generally nuclei will be absent here. The nucleus, initially there will be large nucleus, and slowly when it is coming towards the mature erythrocytes, there will be no nucleus. So please see that the last two, reticulocyte and mature RBC, the nucleus is absent. Whereas in pro-erythroblast, a large nucleus was there. So it shrinks, and then last two stages, there is no nucleus. Similarly, from basophilic, it converts into eosinophilic. So please learn this chart, take a screenshot and learn properly. So the normal values of RBCs, hemoglobin, average hemoglobin content is 14 to 16 grams per DL. But at the birth, it is extremely high, 25 grams per DL. That is normal for the child. After 3 months, it decreases to 20. After 1 year, 17. And after puberty, 14 to 16. So generally, adult males, 13 to 15. Females are a little higher, 14.5 to 16 or 16.5. So that is the, depending upon males also, hemoglobin content, it will changes. Now some clinical anatomy. So what do you mean by hemoglobinopathies? So it is a disorder in hemoglobin. So this, the chemical structure of hemoglobin, the polypeptide chain of hemoglobin, they can vary. So some of the hemoglobinopathies are hemoglobin S, C, E, M. So these are all variants. So hemoglobin in thalassemia and related disorders. So thalassemia is a condition. What happens there? So in thalassemia, different types of abnormal hemoglobin are present. Generally, a normal hemo plus globin, the four structures, the pyrrole ring will be there, four structures, four hemoglobin will be attached, right? But here what happens? There is different types of hemoglobin are present. So little bit, go back into your chapter and read from there. Next condition is called carboxyhemoglobin or carb hemoglobin. So here what happened, your hemoglobin, which is an abnormal, it combines with carbon monoxide. And what happens, carbon monoxide is a colorless gas, odorless gas, and it has got 200 times affinity than the oxygen to attach with the hemoglobin. So because it has more affinity, it will kick the oxygen and carbon dioxide, and then hemoglobin will mix with carbon monoxide, and because of which suffocation, ventilation will happen, and breathing disorders also will come. And if it is a closed place, death can also happen. So ESR. So what is ESR? It is the rate at which the erythrocyte settles downward. So by two methods we check this: Western blot and Winthrop's method. So these are the methods in the Western blot and Winthrop's method. So normal value of ESR in Western blot methods 3 to 7, females 5 to 9, infant 0 to 2. So these things you should learn. These are all applied questions. In Winthrop's method 0 to 9, 0 to 15, 0 to 5. So what are the conditions in which ESR increases following a disease? So generally ESR increase means some infection is there. So tuberculosis, different types of anemias, malignant tumors, liver diseases, ESR increases. And ESR decreases in the following disease, that is your allergy conditions, sickle cell anemia, peptone shock. So these are the conditions where if you will ESR decreases. So please learn this properly. These are all MCQs. The next term what you will know is PCV. So I'm just quickly revising your chapter, okay? So PCV is the volume of RBCs in the blood that is expressed in percentage. So it is also called as hematocrit value. So the percentage is called hematocrit value. So normal PCV males 40 to 45, in females it is 38 to 42. And now there are variation in PCV. It increases and decreases in some conditions. So that thing you should be knowing. So PCV increases in polycythemia and your dehydration, whereas PCV decreases in anemia, cirrhosis of liver, and your pregnancy. So these are the conditions where it decreases. So you should learn and which condition it increases and at which conditions it decreases. You should have a complete understanding of all these things. Now coming to the major part where a lot of applied questions are asked, that is your anemia. So there are four types of anemia based on the size and color. Four types you can call it. Normocytic monochromic anemia. Next is normocytic hypochromic anemia, small. Then is your macrocytic hypochromic anemia. And the last one is your microcytic hypochromic anemia. So the first one, normocytic normochromic. So the size is also normal, the color is also normal. The normocytic hypochromic anemia, the size is normal, but the color, that is your concentration of the hemoglobin, MCHC, is less over here. The macrocytic anemia, the name itself tells that the macro means large, and then what happens? The color of RBC is less. Then microcytic hypochromic, so both are less. The size is also less and the MCHC is also less. These are the four types. MCQs are asked from here also. So now this anemia, loss of blood, hemoglobin content comes down. So this can occur. Various reasons are there. Hemorrhagic anemia, loss of blood, hemolytic breakdown of RBCs. These are the causes what you should know. Nutritional deficiency anemia. This is the classification and different types also you can call it. So nutritional deficiency anemia iron deficiency anemia, protein deficiency, vitamin B12, folic acid. So in each of this condition, which classification does it fall under morphological classification, whether microcytic, hypochromic, macrocytic, hypochromic. So this is an MCQ. In iron deficiency anemia, the size of the RBC and MCHC is what? Four conditions will be given. That is, in iron deficiency, microcytic, hypochromic. In vitamin B12, macrocytic, normochromic, or hypochromic. So like that, we should study this. Then aplastic anemia, it's a bone marrow disorder, and megaloblastic, big size it will be, and hypochromic concentration will be there. Then there are anemias of chronic diseases, rheumatoid arthritis, tuberculosis, and renal failure. So the morphological classification will be normocytic, normochromic anemia. So please learn front to back to front, which all size of the cells will be, how it will be, you should know that. So that was all about RBCs, which you should know, learn, understand, and then only start solving MCQs. Now coming to the next one, that is your WBCs. So WBCs, again, two types are there, with granules, without granules. So with granules are called granulocytes, without granules are agranulocytes. These granulocytes are again three types, BEN, basophil, isophil, neutrophil. So which type of stains they take? The neutrophils generally take both acid and basic stains, whereas your eosinophils will take acidic stain. Basophil will take basic stain. So agranulocytes are plain cytoplasm without granules, and these are of two types: monocytes, lymphocytes. So these are the different types of WBCs. So just learn basics only, nothing much here from this particular slide, nothing much. Lifespan of WBC, this is again very important. RBC is 120 days. So neutrophils is 2 to 5 days. Eosinophils is 7 to 12 days. Basophil is 12 to 15 days. Monocyte is 2 to 5 days. Lymphocyte is up to 1 day. So this is not the way to read like this. You should always read from less to more. So the first one, what you should study is up to 1 days, and then 2 to 5 days. Then 2 to 5 days, 7 to 12, and 12 to 15. Last will be basophil. In that order, you will. Then this lymphocytes, what you are seeing, that is very important for our immunity. And these lymphocytes are of two types, T lymphocytes and B lymphocytes. Now coming to the platelets, the diameter of the platelets is 2.5 micron, it's very small. Volume is 7.5 cubic micron. Normal platelet count is 250,000, and in dengue fever and all, the platelet count decreases. Next is hemostasis. Whenever there is a cut, there is a bleeding, the blood wants to clot. It has to clot. So how does it occur? That is, series of reaction takes place. As a result, the blood flow stops, or coming out of the body stops. It occurs in three stages. First is vasoconstriction, then a platelet plug formation over there, and then the clotting of the blood takes place. So please learn, this is three-step procedure, and only coagulation of blood is the last stage. So this is how it takes place. So whenever there is an injury to the endothelium, collagen gets exposed, and once the collagen gets exposed, platelets will come over there, and activation of platelet takes place. Then your chemical mediators of inflammation type, say serotonin, thromboxane, and prothrombin activator gets activated. So this prothrombin activator is the one which helps in blood clotting, step number 3. So this serotonin is vasoconstrictive in nature. So whatever blood is getting lost, it will get constricted. It will shrink the blood. Then ADP and thromboxane A2 will tell all the platelets come, there is a defect, let us block this. And the platelet plug formation takes place. Stage 1, 2, 3, this is hemostasis. Okay. So factors involved in blood clotting, 13 factors, you should know all these factors and which are vitamin K dependent, non-K dependent. All those things is there in your dental pulse book also. So please go through all of them. This you should be able to tell in order. So blood clotting, as I told you, there are 3 steps again. Only clotting, 3 steps. First is formation of prothrombin activator. and that is done by extrinsic or intrinsic pathway. And once prothrombin activator is activated, with the help of prothrombin activator, prothrombin is converted into thrombin. And this thrombin will help in the conversion of fibrinogen to fibrin. So this is extremely important not to miss this. Okay. So this is your intrinsic and extrinsic pathway. How it comes, you should learn this pathway. It will perfectly. The last stage. Next, coming to heparin. So heparin is a naturally produced anticoagulant in the body. It's an anticoagulant. It will not, our blood is always in the liquid state because of the presence of heparin. So this heparin, which is an anticoagulant, because of which the blood is in the liquid state, is produced by mast cells. Very, very important MCQ, mast cells. So the heparin gets activated, released, then the suppression of thrombin action takes place, and then activates antithrombin 3. This is against the clotting. So just whatever you have studied in clotting, it is reverse of that. It removes thrombin. Their thrombin formation was there. So here removes thrombin and no blood clot. So blood always will be in the liquid state. Then you have got coumarin derivatives. So this is your dicumarol and warfarin are the derivatives of coumarin. So the coumarin derivatives prevent blood clotting, and vitamin K is essential for the clotting factors 2, 7, 9, 10. So please learn all of these clotting factors. Then you should have a vague idea about bleeding time, clotting time, prothrombin time. Bleeding time is 3 to 6 minutes, clotting time is 3 to 8 minutes, and prothrombin time is up to 12 seconds. So this prothrombin time is generally what they ask in the exam. It is prolonged in prothrombin or factors of 1, 5, 7, 10 deficiency. So if these factors are not there, prothrombin time is increased. And it is normal in hemophilic patients. Clotting time is increased in hemophilic patients. Bleeding time is increased in purpura or platelet disorder patients. Then coming to your antigen antibody reaction, that Rh negativity, right, or positivity, what we study. So that we study. So it is an antigen antibody, Rh. So for group A, in the antigens in the RBC will be A only, and antibody anti-B will act. In group B, antigen in RBC will be B, and antibody in serum will be anti-A. For AB, antigen in RBC is A and B, and for an antibody, there is no antibody. For O group, antigen in RBC is no antigen, and antibody in serum is anti-A, anti-B. See, I'm going a little fast with this chapter because this is all read so many times in first year, second year, third year. Every year you are reading this. So generally, in the Asian population, Rh is positive in 85% of the people and 15% only it is negative. So please remember this key points. This was discovered by Landsteiner and Wiener. Why it is called as Rh factor is because first identified in rhesus monkey. So Rh. And D antigen is the most important and antigenic Rh antigen in humans. So these are the things what we should learn. Coming to blood groupings. So this blood groupings, you should do matching, cross matching because you are doing blood transfusion. So no natural anti-D bodies are present at birth. So there is no antibodies are there at birth. Then the first Rh positive transfusion in Rh negative person, antibodies develop slowly. Then over a period of time, mild delayed transfusion reaction, antibodies persist for the life. And then the second time, Rh positive transfusion happens, severe immediate reaction occurs. So this is erythroblastosis fetalis, what is being explained. So this erythroblastosis fetalis, I have just told you. So MCQ when it comes, we'll discuss this. So when erythroblastosis fetalis occurs, so there is a breakdown of erythroblasts, that is RBCs. So it leads to severe anemia and jaundice. So severe anemia and jaundice occurs. So this occurs because of RBC production bone marrow and liver spleen also. From that side, the problem arises and destruction of RBCs is there. So because the destruction is happening at a faster rate, release of immature erythroblasts, even though they are not mature, they are thrown into circulation. So this condition is called as erythroblastosis italis. Okay. Now coming to an MCQ, the deficiency of coagulation factor 9 is associated with what? Hemophilia A, hemophilia B, or phenolphthalein purpura. So this is a direct question actually of sickle cell anemia. It is hemophilia B. So this is what is being asked for. Hemophilia A is deficiency of factor 8. Hemophilia B or Christmas disease is from factor 9. Hemophilia C, deficiency factor of 11. Von Willebrand's disease, deficiency of von Willebrand factor. And parahemophilia is deficiency of factor 5. So learn this. This is extremely important. It comes in your exams also. Next condition or next question. In Hanoch-Schoen's purpura, there is all except so abdominal pain and proteinuria. Yes, that is present. Acute arthritis, rectal bleeding, and common in adults. So common in adults, it can happen actually anywhere. So that is not possible. That can happen to anyone. Next, coming to the prothrombin time and partial thromboplastin time. So this is extremely important slide. Take a screenshot of this. So prothrombin time is assessed by your extrinsic pathway, whereas your partial thromboplastin time is assessed by your intrinsic pathway. So one is extrinsic, one is intrinsic. Both are different. The normal prothrombin time is 10 to 14 seconds. That is normal. So there can be increase and decrease, and it is normal in hemophilic patients. So this prothrombin time is increased in conditions or deficiency of factors 1, 2, 5, 7, or vitamin K deficiency, liver diseases, it's increased. Partial thromboplastin time, PTT, is assessed by intrinsic pathway, which I told you. And the normal value is 26 to 37 seconds. So please understand that is 10 to 14 seconds. This is 26 to 37 seconds. And the conditions where it is increased is deficiency of factors 1 to 5, 8, 9, 10, 11, hemophilias and liver disease. So you have to learn all those things step by step only in one single day. Everything cannot be read. But because I am condensing this class, I am going at a faster rate. You cannot go at this rate. So learn slowly, and it's an easy chapter. That's why I am fast. So bleeding time 1 to 5 minutes by Duke's method, by Ivy's method 2 to 7 minutes, clotting time again capillary method. So these are all things what you have studied for your Viva in first BDS. Just you have to revise this things again. Then clot retraction time. It is the platelet adhesiveness and platelet aggregation. The platelets will come and stick at the injury site. So adhesiveness and aggregation is determined by clot retraction time. Usually it is 6 hours and it should be completed in 24 hours. So within one day it should be finished. But this condition is again impaired in thrombocytopenic purpura. So very important term, thrombocytopenic purpura. So what happens here? Thrombocytopenic purpura is increase in platelet, decrease in platelet, normal platelet. So the name itself is telling thrombocytopenic. Penic means it's less. So it is decrease in platelet count. Normal count 1.5 to 4 lakhs. Abnormal increase in number of blood platelets is called thrombocytopenia. And then abnormal reduction is thrombocytopenic purpura. That is thrombocythemia. This is thrombocytopenia. Both are different. One is increase, another one is decrease. Next question, aplastic anemia. So this is directly taken from the morphological classification what I have discussed. In aplastic anemia, there is normocytic, normochromic with thrombocytopenia, megaloblast, hypochromic, microcytic, hyperchromic, microcytic. So in aplastic anemia, it's not proper. So there is option one is the answer: normocytic, normochronic, and thrombocytopenia. So this is what you should learn about, and this is there in your dental pulse book. Try to understand and learn. If you are having difficulty, please let us know. Today's session is a quick review of entire chapter. Next question. WBC count of more than 1 lakh cells of the blood indicates, so it is extremely high. Leukopenia, leukoplakia, leukocytosis, or leukemia. It's abnormal increase, so that is leukemia. It's a clear-cut question. So erythroblastosis fetalis, we have just read erythroblastosis fetalis. So here there is deposition of bilirubin pigment in enamel and dentin, blue color. Bilirubin developing primary teeth, giving them green or brown or bluish hue. Bluish color teeth will be there. Okay, bilirubin deposition. A question: children of parents with having following group combinations have high risk of erythroblastosis fetalis. So this is when Rh positive father and Rh negative mother. So first child generally no problem, but when the first child is delivered, the antibodies against Rh positive is developed. Then when the second childbirth takes place, so already the antibodies are ready, antigen antibody, they fight at a faster rate, and then a big problem happens, a jaundice and all, severe problem occurs. Anemia, splenomegaly, and structural defects are seen in. So this is nothing but seen in thalassemia major. Okay. So this is what thalassemia major. So thalassemia is of two types: thalassemia major and thalassemia minor. So this thalassemia major is present in infancy, small kids, and then hypochromic anemia. It's seen more hypochromic hepatosplenomegaly. So that is enlarged, bony changes takes place. So this defect is because of the globin chain is defect in hemoglobin, the globin. So these are different types, classification of, you can call it what you want, Willebrand disease. So type defect is 1, 2A, 2B, 2M, 2N, 3. This is more than what is required, but just please read this, it will be useful. So von Willebrand disease is transmitted as what? So von Willebrand disease is transmitted as autosomal dominant, recessive, X-linked, or Y-linked. So this is nothing but autosomal dominant. Hemophilia is transmitted as X-linked recessive, while von Willebrand disease is autosomal dominant. So this you should know that. So coming to von Willebrand's disease, what you see here, so it's common condition, but with mild bleeding disorder. So here there is a quantitative type 1 or type 3 or qualitative. So there are different types also of von Willebrand disease. This deficiency of von Willebrand factor will be there because of lower plasma or factor level and impaired platelet plug formation. DIC is called disseminated intravascular coagulation. It can occur because of multiple reasons. So infection, cancer, obstetric problem. So as a result of DIC, there is thrombocytopenia, prolonged prothrombin time, prolonged partial thromboplastin time, and increased level of D dimer. So this is a very huge condition, very serious condition, and it can lead to death also very fast. Okay. The most important, just a second, the most important aspect in treating DIC is what? So that is nothing, address the heparin platelets, treat the underlying disease process, and achieve normal level of fibrinogen. So that is more important. Achieve normal level of fibrinogen as far as possible. So which of the following is not seen on hemoglobin electrophoresis in sickle cell anemia? So when you do this electrophoresis in the hemoglobin of sickle cell anemia, what is not seen is hemoglobin, adult type of hemoglobin is HbA, the aplastic type. Next question. A 20-year-old female came to medical OPD with severe pain, redness over the dorsum of the foot. Abdominal pain was there. Peripheral smear showed anemia and poikilocytosis. Abdominal shape and size, everything. So the likely diagnosis is it's abnormal. So it is sickle cell anemia. So your sickle cell anemia is nothing but it is a result of single glutamic acid to valine substitution. So that change is the problem. Disease which results from single glutamic acid to valine substitution at position 6 of beta globin. So at that level, the change is taking place. These are all okay. So the investigations, blood film investigations, sickle cell target cells, you will be able to appreciate there. And definitive diagnosis is hemoglobin electrophoresis. So what is the management? See, I am focusing on the major areas where questions are asked. It's not that everything what is there on the slide is important. Please understand that. The most important ones I'm trying to highlight so that you will hear it and focus on these areas. So, what is the management of this condition? So, prophylaxis with daily folic acid you will give. The folic acid iron content should be managed, and then vaccination against influenza can be given. Vaso-occlusive crisis managed by aggressive rehydration. You have to give a lot of plenty of water, ORS solutions, oxygen therapy, adequate analgesia and antibiotics if infections are more, and if required, transfusion of the blood. That can be done. So this is the areas what we need to focus on blood chapter. The questions will be twisted, but these are easy questions. This you have again studying in pathology also and in your oral pathology also, general as well as oral pathology also. So learn this very carefully. Blood chapter questions you are not supposed to miss. So read anemia and the thalassemia questions and all, it will proper. Coming to endocrinology, so you should know endocrinology, all the hormones, their actions, which gland produces what. So we have got so many endocrine glands from pituitary to parathyroid, thyroid, adrenal, pancreas, ovary, testis. So this is the classification, come everything you call it. Anterior pituitary, which are the hormones, posterior pituitary, which are the hormones. Either they can ask you the question and like anterior pituitary will be in the option or it will be in the question. So you have to know either way they can ask you. Adrenal cortex makes mineralocorticoids, glucocorticoids, and sex hormones. Whereas adrenal medulla, they makes catecholamines. So your adrenaline, what you get in injections, local anesthetic injections, adrenaline is from adrenal medulla. Then testis, testosterone, sex hormones are there. Then hormones are secreted by other glands also. Pineal glands, heart also manufactures some hormones, thymus, placenta, kidney, and local hormones are there which will act only on those places. This particular chart is extremely important. You cannot miss this. Please read this chart properly. So now coming to the classification based on chemical nature. So you've got steroids, proteins, and derivatives of thyrosin. This is based on chemical structure. Under steroids, a big list is there. So steroids are the ones which have anti-inflammatory action. So that is why the steroids are given before a surgical procedure, so that the swelling and infection is reduced. And because of the use of steroids, the efficiency of the person is increased. So that's why in sports persons, steroid is banned. So in any medicines if the sports person takes and steroids are found in the urine, then the sports person will be banned. To learn this table. So coming to the first one, that is your pituitary gland, you have got anterior lobe and middle lobe and the posterior lobe. At different lobes, different hormones are made. You should know the names and from where what is made. From anterior lobe of pituitary, you've got adenohypophysis, that is called as. So you've got acidophilic cells and then basophilic cells. Acidophilic cells produces growth hormone. Basophilic cells will make thyroid stimulating hormone, anticotropic thyrotropic hormone, FSH, LH, luteinizing hormone, follicle stimulating hormone. So these are the hormones which are manufactured for anterior lobe of pituitary. And from the posterior lobe, you have ADH and oxytocin. So this means from which lobe what is manufactured, you should know that. Then the pituitary gland, if the hormonal dysfunction is there, if there's a anterior pituitary is a problem, or if hypersecretion is taking place from anterior pituitary, then gigantism, acromegalic gigantism, and Cushing disease, 4 condition occurs. And if anterior pituitary is not working, dwarfism, acromicria, Simon's disease occurs. Then if the defect is in the posterior pituitary, hypersecretion of ADH happens and diabetic insipidus. And anterior and posterior pituitary both are not working properly, then dystrophagia, adipogenititis happens. So a lot of fat depositions in the genital organs happen. So this is the disorders of pituitary gland. Please read this. So many times questions have come from here. Next is your thyroid gland. So it is an endocrine gland. So you know where the location of the thyroid. It's about 20 to 40 grams in adults and a little larger in female. So the basic hormone, the thyroid gland is basically BMR maintenance, basic basal metabolic rate. So thyrotropic releasing hormone TRH will activate the anterior pituitary, and from the anterior pituitary, thyroid stimulating hormone will be made. It is manufactured via the thyroid gland, and T3, T4 are the hormones. So these thyroid hormones, T1, T3, T4 are the major ones. So T4 or thyroxine forms, they are about 90% of iodothyronines. T3 forms 8 to 9%. So it is basically the T4, which is the more potent variety of thyroid gland hormones. T4. So hypothyroidism, this you are reading from a very long time. So all primary, secondary type, please learn all those things properly. So the goiter in hypothyroidism, there is increasing size of the gland and increased hormone secretion. So the gland, big mass type, ball type structure will be moving here. So goiter in hypothyroidism is called toxic goiter. It is very, very harmful. And the goiter in, where it is called as non-toxic goiter, in hypothyroidism, it is called as non-toxic goiter. In hyperthyroidism, it is called as toxic, and in hypothyroidism, it is called as non-toxic. So regulations of calcium, plasma calcium level, you should know this. This is very, very important. So parathyroid hormone, vitamin D, this you have studied in biochemistry also, vitamin D chapter. Right, so I'm not going into details, but this values increase, decrease, these are all changed into MCQ. Then endocrine functions of pancreas, you have got alpha cells, beta cells, delta cells, and F cells. 4 types of cells are there in pancreas. So from beta cells, you get insulin. From alpha cells, you get glucagon. Then from delta cells, you get somatostatin. So this also composition and all. Please read this. Tendency to get confused, it can be there. And insulin decreases the blood glucose, glucagon increases the blood glucose. So one is given in diabetic shock when the person goes into shock. One is given in hypothyroidism. Another one is given in hyper diabetes, right? So whenever the insulin glucose content is less, hypo and hyper. So if there is insulin is given, major function of insulin will be to decrease the blood glucose. So in hyper diabetic values, these are given. And Glucagon is given to increase the blood sugar level. When your hypo condition is there, that time hypoglycemia will be there. That time you can give glucagon. So actions of insulin, this is very important. This mixes with biochemistry questions also. So in which conditions carbohydrate, protein, fat, and the growth, how they influence the actions of by the insulin. Then this is by the glucagon. This is the diabetes mellitus. So diabetes mellitus is type 1 and type 2. Type 1 age causes is insulin deficiency and beta cell destruction is there. Yes, insulin therapy is always required here. Body weight is very thin, whereas in type 2 non-dependent type, greater than 40 years of age, insulin resistance is the cause. Beta cell destruction is not there. So this differences you should know of type 1 and type 2. Basic terminology: polyuria, polydipsia, polyphagia, glycosuria, acetone breathing, phosphorus breathing. This is straightforward questions. No excuse if you don't know this. Please learn this. Then from the adrenal cortex, you have got cortex and medulla from the adrenal gland. So from the cortex, you've got three types of hormones: mineralocorticoids, glucocorticoids, sex hormones. So from the mineralocorticoid, aldosterone is the major hormone which comes. Glucocorticoid, your steroids, cortisol, and sex hormones, DHEA and your androstenedione, they are the major hormones. So aldosterone, your corticosteroids, if there is an inflammation, infection, or you are planning to do a surgery, so before the surgery, you can give the steroids, and then the infection, inflammation will be very less. So it's a basically that is for corticosteroids. But your aldosterone, which is your mineralocorticoid, it's a life-saving drug. Very, very important. The life-saving drug is aldosterone. The glucocorticoids, I told you, it's anti-inflammatory. So please learn this. This is all part of your biochemistry also. Then comes your Cushing syndrome. Your Cushing syndrome is your moon face deformity, buffalo hump. A lot of fat is deposited, pot belly, muscle weakness will be there. So this there is two terminology: Cushing's disease, Cushing syndrome. Cushing syndrome is because of the pituitary gland problem. So pituitary adrenocorticotropic hormone problem, whereas Cushing syndrome is the adrenal causes. One is from pituitary origin, another from the adrenal gland. So the Addison's disease, there is decrease in cortisol plus decrease in aldosterone. So this is how all questions will be asked. So this presentation is just the applied aspect of what is expected as questions. The features of Addison's disease: hyperpigmentation, hypotension, hypoglycemia, weight loss, all will be there. Next, coming to your gestational diabetes. It's during pregnancy, the diabetic happens. So this condition is called as gestational. So gestational diabetes develop only during pregnancy. So that is the most important thing. All of the following occurs in adrenal deficiency except. So in adrenal deficiency, hypoglycemia is there, yes. Hypocalcemia, no. Hypotension, yes. Hyponatremia, yes. So that's the same thing what is we have studied in the tables and charts, that is kept in as a question. Hypokalemia, this is all your acid base balance. There you should know hypokalemia, it's your decrease in the potassium. Hypokalemia, hypo means less, decrease in the potassium. The causes of this are potassium is recirculated, redistribution, or decreased potassium intake, or excessive potassium loss. Renal problems and GIT problems can also aggravate hypokalemia. So the question: hypokalemia is likely seen in insulin therapy, Addison's disease, starvation, hemolysis. So it is likely seen in your the first one, that is your insulin therapy. A 41-year-old person. So this is how questions are asked. You see this in the NEET exam. A 7 or 8 line questions will be given based on that 2 questions or 5 questions will be there. This is directly picked from the original question bank. A 41-year-old man is presented to the emergency department with a 9-month history of cough, exertion dyspnea. Then there is your nocturnal diaphoresis, weight loss. Examination tells painless, massive supraclavicular cervical lymphadenopathy. So lymph nodes are also enlarged now. Radiograph shows the chest shows bilateral healer lymphadenopathy. Serum calcium level was elevated to 16.2. Parathyroid hormone is within the normal range. So now it's a big clinical scenario. So this is all features of actually Hodgkin's lymphoma. Hodgkin's lymphoma, yes. Right, so please learn this properly. All these conditions you should learn, then only you come to know. Then your urgent treatment instituted for him would be, what would you give to this person? Intravenous administration of normal supply by bisphosphonate. Yes, bisphosphonates, because he's having lot of bone problems also. Calcium level is 16.2. 9 to 11 is the normal. Here it is 16.2. So bisphosphonates. Even in fibrous dysplasia, cherubism, bisphosphonates are given. So that is the answer. The word bisphosphonate, I connected with the calcium and the bone. So now same question is continuing. A diagnostic investigation was performed on him. So the lymph nodes are there. Excisional biopsy of the axillary node. It is easily accessible. Easily you can do that. Then the treatment regimen consists of, these are all suggestive. Lymph node is there involved. So it is all suggestive of tuberculosis. So anti-tuberculosis first line of drug, INH, rifampicin, ethambutol, and PAS. That will be done. So polyuria, excessive fluid intake, so passage of urine is more, and it can also, because of diabetes insipidus, it can happen. Osmotic, nephrogenic, these are the different reasons. Which of the following is not a cause for polyuria? So the question is there on the same slide only. Which of the following is not as hypocalcemia? Right. So this was in a very quickly manner we went. In 1 hour, we finished 2 biggest chapters of physiology. So the whole idea of the presentation was to give you the gist, what all areas you need to cover. Yes, I was a little fast today, but this is to make sure you get to know what you have to read in this chapter. Otherwise, you will be wasting days and days, days and days. So now the areas, how it is asked, how questions are twisted, you came to know. So with this concept, then you read your synopsis, start doing MCQs, the tables, charts, everything related to that. Then only you will be able to answer questions if you have the complete fundas very clear. Okay, so that's all for today's session. Go back and do as many MCQs as possible, especially from the hormones chapter. Hormones chapter, that is endocrinology, they will give you clinical situations. And blood chapter, direct questions. So blood chapter will be all high yielding facts or direct, generally. Okay, so that's all for the day. Thank you.